Hello, thank you for joining the webinar today, where we will be doing a deep dive on the care coordination and patient safety measures that help make up part of the measures for the Centris Health MSSP ACO. My name is Cindy Campbell. I am the Director of Clinical Strategies and Quality with Kansas City Metropolitan Physicians Association. The purpose of these webinars is to not only educate you all on the phone today and watching this webinar, but also to take this information back to your care team, back to your providers, so that they have an understanding of what the MSSP requirements are as well. And also, if you need to go back and do a refresher, we do have a Centris Health MSSP ACO 101 webinar that's available on the YouTube channel, as well as a webinar that is a deep dive into the patient experience measures. This slide shows the practices that make up the Centris Health MSSP ACO and the number of attributed lives for each of the practices. The quality measures for the ACO are 31 quality measures across 4 different domains. We have the patient caregiver experience, care coordination and patient safety, the preventive health measures, and the at-risk populations. There is a recorded webinar currently for a deep dive for the patient caregiver experience measures. And then today we will be doing a deep dive into the care coordination patient safety measures. And then future webinars will do a deep dive on the preventive health domain and the at-risk populations domain. This chart shows the number of measures that make up each of the domains and the weighted score. So if you see the second line there under for the care coordination and patient safety, it's made up of 10 different measures, which will be 25% of the weighted domain. You can see on this slide all of the measures that make up the care coordination patient safety domain. So this lists out all 10 of the measures. Some of these will be pulled via claims. Some of them will come from your EHR, and then one you will be reporting on. So I'm going to go through and do a deep dive on each one of those categories. So the claims, what we can do to affect those that are pulled via claims, and then the one that you will have to be submitting on, and then the ones that will come from a wireless interface or from the EHR. Okay, so claims-based measures. So claims-based measures are those that CMS will be looking at claims for your attributed lives under the MSSP ACO, and that number will come from those claims. So this is going to be around readmissions and admissions, or hospital admissions, and then also the use of imaging studies for low back pain. So there's some things that we can do to help affect the claims-based measures that we can do in the practice. And one of them is by decreasing the number of 30-day readmissions. And one of the ways that's been proven that we can do this is ensure that patients have a transitions of care visit and to see their primary care physician after a discharge from a hospital, a skilled nursing facility, a long-term care facility. So ensuring that they get in to see their primary care physician within that allotted time frame, that a post-discharge medication reconciliation is performed, and just really overall catching anything that might cause that patient to go back into the hospital, being able to catch that early so that we can ensure they don't have a 30-day readmission. And then what are we doing in the practice to decrease hospital admissions overall, especially for our patients that have chronic conditions? Do we have good workflows that are happening in the practice that we're utilizing the entire care team, so that it's not just falling back onto the physician? Are we utilizing care managers? Are we utilizing care coordinators, dietitians, diabetic educators? What are we doing to help manage these patients that have chronic conditions and that they're high risk for being hospitalized? And then also looking at access to care. Where are we referring these patients if they happen to call in later in the day, or if they're calling their specialist and they're not feeling well? Are we encouraging them to get in to see their primary care physician? Most primary care physicians, especially those for the MSSP ACO, have extended hours. They have same-day access. They are doing a lot to ensure that patients have access to care, and that we're not sending these patients right to the emergency room. And then reducing imaging for low back pain for those ages 18 to 50. The recommendations around acute low back pain is conservative treatment. So if you look at low back pain, if you go into Choosing Wisely, their recommendations are the conservative treatment, and that we don't immediately send these patients to have MRI or CAT scans or any type of imaging. So these are just some things that we can do at the practice level that will help affect the claims-based measures. Okay, so the use of certified EHR technology. As you recall, the one and only area that you will have to be reporting on at the practice level for MIPS is the ACI, which is Advancing Care Information, which is now going to be known as Promoting Interoperability. And the use of a certified EHR technology will be part of that area that you will be reporting on at the practice level. And then we move to the wireless interface measures, or the electronic health record. So these are the measures that we will be pulling right out of your EHR. And these will be ACO 12, medication reconciliation post-discharge, and ACO 13, falls or screening for future fall risk. So ACO 12, the medication reconciliation post-discharge, this is the percentage of discharges from any inpatient facility, so hospital, skilled nursing facility, or rehab facility for patients 18 and older, that they are seen within 30 days following a discharge in the office by the physician or another provider, or a clinical pharmacist, a clinical person in the practice, that they are doing a discharge medication list reconciliation, that they are looking at that discharge list along with their current medication list that they already have in their outpatient medical record. So one of the things that KCMPA practices that we have encouraged is the use of a clinical pharmacy, using a clinical pharmacist to do this medication reconciliation post-discharge. And we use the pharmacist via TRIA, which is a consulting company that are made up of clinical pharmacists. And this has been a great way to get this medication reconciliation post-discharge done. So you need to remember that if this is happening in your practice and you have a discrete field that you can check to say this patient has had a medication reconciliation post-discharge, please make sure that that's being done or it's being documented somewhere that that patient had a medication reconciliation post-discharge. One of the things that we do in the primary care practices, they do have a good workflow already in place. We've been working on this for a long time, and we're really just looking at how are we refining that, and how are we in the practice, do we have somebody that is going back in and doing quality checks? Do we have somebody intermittently that's pulling your patients that have been discharged, and that we're ensuring that we have that documented in that chart, because that's how we're going to be able to get the credit for that measure. So what we'll be looking at is the denominator is going to be all discharges from one of these inpatient facilities that we've discussed that are 18 years and older, and so that's going to be looking at all of those discharges, and then the numerator will be that a medication reconciliation was conducted within the 30 days of discharge. So once again, ensuring that you have that documented so that when we go to pull all of those, or that we pull that list of patients, that CMS will give us a sampling of patients, and then we can go right into their EHR and we can see that this was done. So just to give you a little bit more information on this, CMS defines it as a type of review in which the discharge medications are reconciled with the most recent medication list in the outpatient medical record. Documentation in the outpatient medical record must include evidence of medication reconciliation and the date on which it was performed. So the guidance is that this denominator is going to be based on discharges followed by an office visit. So not the number of patients, but the office visit. So a patient may appear in the denominator more than once if there was more than one discharge followed by an office visit in the performance period. Okay, so then ACO 13, falls or screening for a future fall risk. So this is going to be the percentage of patients 65 or older who were screened for future fall risk during the measurement period. So the measurement period, of course, will be for the 2018 reporting period. So the denominator is going to be the entire patient population that is 65 or older, and then the numerator is going to be those who were screened for a future fall risk at least once within the year. So one of the ways that we do encourage that this is to be done, be performed, especially in our primary care practices, is by getting an annual wellness visit done on every year. So we encourage within our primary care to get the Medicare patients in, get an annual wellness visit done, and then a lot of these measures can already be taken care of during that one visit, and it can be documented on. So for specialty practices, encouraging your Medicare patients to get in and see their primary care physician and get their annual wellness visit will help to get these measures accomplished, and so that we can get credit for these come time to submit. So the definition of the screening for future fall risk is assessment of whether an individual has experienced a fall or problems with their gait or balance. A specific screening tool to measure this is not recommended. There is nothing that CMS says you need to use. However, they do just say that a potential tool like the Morse Fall Scale or the Time to Get Up and Go test. So something that the patient or the practice can decide on their own, whatever screening tool that they like to use or they want to use. Okay, so that ends our webinar today on, um, on the domain of care coordination and patient safety. And so if anyone has any questions, please do not hesitate to call me or email me. And my contact number is here. Most of you already know how to get a hold of me, so please do not hesitate. And soon there will be the next webinar on the next two domains. Thank you.